The rest of the neurologic examination will not take long to go through. We just have to talk about reflexes and gait testing. And for this lecture, it would be important that you watch the video links that I've included in Canvas that illustrate this, including me doing a neurologic examination on actually a medical student, checking reflexes and some of the other things that we've talked about in class. So reflexes involve striking the tendon, which then will stretch the muscle. In this case, we're striking the patellar tendon with a reflex hammer, which is going to stretch the muscle. And we'll explain later in more detail how this works, but when you stretch the muscle spindle is stretched as well, and that sends a signal here into the spinal cord. And later on, when we talk about these sensory nerves, we'll classify them in different categories based on how fast things travel. But 1A sensory fibers are the fastest. All right, so this goes into the spinal cord, and right here, this is an anterior horn cell, otherwise known as an alpha motor neuron. So when we talk about lower motor neurons in the spinal cord, this is it. All right, so when you check reflexes, you are directly stimulating these anterior horn cells, or alpha motor neurons. And this is unique. In fact, it would be worthwhile just writing down, this is monosynaptic. Okay, it's not polysynaptic. All of the other things when we go through the spinal cord lecture that enter the spinal cord, there's an interneuron involved. But when we check reflexes, we are immediately and directly stimulating the anterior horn cell, which then sends a motor fiber right back to the muscle that was stretched, causing it to contract. And that's why the leg will kick out, right? That's the action of the quadriceps muscle. Right, so that's the principle involved here for all of these reflexes, which are often called deep tendon reflexes. Really, the best accurate term is to call them muscle stretch reflexes. We're stretching the muscle, and that causes the muscle to reflexively contract. So here's a more detailed picture here of this 1A fiber coming in, and it synapses on the anterior horn cell directly. And later on in the spinal cord lecture, we'll talk about the significance of what happens with all of the interneurons here in this process. All right, so reflexes, in the upper extremity, we check brachioradialis, biceps, and triceps. And next week, we will go over the nerve roots and the plexus. All right? And so for now, I'm just going to have you know the nerve roots that are associated with each of these. So when you check the brachioradialis and biceps reflexes, remember both of these muscles flex the elbow. Okay, this goes into the spinal cord, and in and out it goes through the C5 and C6 nerve roots. So it's a really nice assessment of those two nerve roots. Triceps gets actually three nerve roots. C7 is by far the most important, the most predominant contribution to the triceps, but it does get a little bit of C6 and C8 as well. Okay, in the lower extremities, the patellar is quadriceps, which gets supply from L2, 3, and 4. And the Achilles reflex, here we tap on the Achilles tendon, that stretches the gastrocnemius muscle, which is supplied by the S1 and 2 nerve roots. So in the last lecture, we introduced the idea of upper and lower motor neuron lesions. All right, and so remember, the lower motor neurons are the ones that come from the spinal cord and go out to the muscles. So these nerve roots here are lower motor neurons, right? The muscle fiber is going right out to the muscle. And so if we were to have a lesion, let's say of the C5, C6 nerve roots, then the patient would lose the biceps and brachioradialis reflexes. They would be absent. If we have a lesion a little further down, again, especially C7, then the triceps reflex will be diminished. Okay, if we have an L2, 3, 4 root lesion, the patellar will be out. And with an S1, 2 root lesion, and this is the most common root lesion, an S1 radiculopathy. Remember, that's the term for a nerve root lesion. then the Achilles reflex will diminish. Okay, so reflexes diminish with a lower motor neuron lesion. So just like with the motor grading for strength, we have a scale. We also have a scale so that you can communicate with others, and also in a follow-up patient that you'll be seeing, you can remember what the reflexes were last time so you can compare. So this is a 4-point scale. 0 means there are no reflexes. They're absent. Now, some individuals just don't have reflexes. I usually demonstrate reflexes at some point for the class, and one year a medical student came down and he has no reflexes. So that can be normal, all right? But in general, if someone has absent reflexes, and certainly if there's any weakness, diminished reflexes are a lower motor neuron process. So remember I said if you have a C5, C6 nerve root lesion, you're going to lose the biceps and brachioradialis reflexes. It's a lower motor neuron process. Okay, a 1+ is hypoactive. That means you can get them, but they're not very brisk. And there are some maneuvers I'll show you at some point for how to bring out reflexes if they're, not very, easy to elicit. A 2 is normal, and you'll need some experience to, know what normal is when you're checking reflexes. A 3 is they're brisk, but they're still normal. Okay, and the asterisk here is the key thing really when we're checking reflexes is that we need to compare side to side very carefully. Reflexes should always be symmetrical on the right side and on the left side. So if someone has 3+ reflexes on one side of the body and 2+ reflexes on the other side of the body, even though these are still, a 2 or 3 are still normal, if they're asymmetrical, they're abnormal. And the 3+ on one side of the body would suggest we have an upper motor neuron process involved there, right? So reflexes go away with the lower motor neuron process, and they increase with an upper motor neuron lesion. So remember the corticospinal tract. If you have a lesion anywhere along that pathway in the brain, brainstem, or as it travels down the spinal cord, then the reflexes will increase. So if we grade a reflex as 4+, that's always abnormal. It's hyperactive, and with hyperactive reflexes we have clonus, okay, which I will show you I think on Friday. A patient that has clonus. This is a rhythmic movement of the foot. When you dorsiflex the foot, it keeps shaking. Okay, and so clonus is associated with hyperreflexia, abnormal reflexes, and so that is upper motor neuron. So a reflex that we always check on examination is the Babinski. The term extensor plantar response is more descriptive of what we're actually doing. So you take a sharp object, usually the end of a reflex hammer, which is sharp, okay, and you apologize to the patient first because this is rather uncomfortable, all right? And so you strike the outer part of the foot here on the dorsal aspect, and you kind of move forward to the toe, okay? And normally, the toes will curl down, or, like in this example, some patients are very ticklish and they'll withdraw the whole foot. But an abnormal response here, positive Babinski, is where the big toe goes up, and sometimes the other toes will kind of fan out along with it. All right, so a positive Babinski or a positive extensor plantar response is another upper motor neuron finding. So if we see this, the lesion has to be in the brain, brainstem, or spinal cord, because that's where the upper motor neurons travel. So we have a patient that has very brisk reflexes. We're really interested then to see what's the, Babinski going to show. And if that shows an upgoing toe, now we've just confirmed, okay, we really do have an upper motor neuron lesion going on here. Now, some other reflexes called frontal release signs. We don't check routinely, but especially in adults, we check them in patients that have a neurodegenerative process like Alzheimer's disease. So frontal lobe release signs are reflexes that are present in infancy. They go away with the normal maturation of the nervous system, but in disease processes later in life, these reflexes can reemerge. So the glabellar reflex, you basically take your finger and you tap on the glabella, or the forehead, and you ask the patient just to look straight ahead. Okay, if you check this in a normal individual, they'll blink once or twice and then they will stop blinking. Okay, in someone with Alzheimer's disease or anything that involves a lot of degeneration of the frontal lobe, as you continue to tap gently on the forehead, the eyes continue to blink. Right? The snout reflex will tap usually on the side of the mouth, like with a tongue depressor. We'll tap with our finger and we'll see some puckering of the lips. The Palma Mental is a very strange reflex. You take a sharp object, again like the end of your reflex hammer, and you scrape it on the patient's palm. And what you see, curiously, is that the mentalis muscle, the ipsilateral chin, will wrinkle, will curl up when you do that. So that's a Palma Mental reflex. Don't ask me the anatomy of how that works. It's really complicated. But this is something, again, we'd see with like an Alzheimer's, a lot of frontal lobe degeneration. The grasp reflex is where you ask the patient just to relax. Maybe they're sitting in a chair or lying down on a bed, and you gently stroke their palm like with your index and long finger, and just ask them to relax. And a grasp reflex is where the patient needs to grab onto your fingers as you do that. So again, Alzheimer's disease would be classic, and in an advanced patient with Alzheimer's disease, the grasp reflex can be so strong that you can just touch the palms, the patient grabs on tightly, and you can lift the patient out of the bed with the grasp reflex. All right, finally, gait testing. So first we're going to have the patient walk normally. It's hard to walk normally, when you have people, medical students, all watching you, but we try to, have the patient relax, just walk down the hallway and come back. And we're looking for a number of things when we have someone walk. We're looking to see, are the legs moving symmetrically or asymmetrically? Does the patient seem to have fluid movement? We look at the arm swing. Are the arms swinging symmetrically and normally when the patient walks? When the patient turns the corner, can they do that easily? Because someone with a gait problem, it's often difficult for them to navigate turning. All right, and if the patient is able, we'll make it more difficult, and we'll do what is called Tandem Gait testing. And this is otherwise known as heel to toe. And you basically ask a patient to walk a line, one foot in front of the other. Okay, that makes it more challenging, and it makes it more likely that you're going to bring out any abnormality with walking and balance. And so there are a number of things here, abnormal types of gait, and when you get good at this, it can be kind of rewarding. You can just sit at the mall, watch patients walk, and try to figure out what sort of a problem that they might have. So you want to separate gait problems into either asymmetrical, so the problems in one leg, or symmetrical gait abnormalities. So Trendelenburg is generally hip pathology or weakness of the gluteus medius, which is a abducting muscle of the hip. And so this is something I will talk about next week when we get to L5 radiculopathies, because the L5 nerve root supplies the gluteus medius weakness. And when these patients walk, the hip drops down. Okay, so I'll show you what that looks like. Another hemiplegic gait, or another asymmetrical gait, is a hemiplegic gait. So this is when someone's had a stroke and they're weak on the opposite side of the body from their stroke, right? So this is an upper motor neuron type of gait, usually a stroke. And what happens when someone's had a stroke that involves the arm and the leg, over time the arm moves into a flexed position. And interestingly, the leg, and especially the foot, goes into an extended position. All right, so a lot of people you'll see walking around like this with a flexed arm, and if your toes are extended, they're pushing down to the ground, then when these patients walk, they need to swing their leg around to avoid dragging the toe on the ground. This is called circumduction. So they swing their leg around and the arm is flexed. So if you see someone like that, you know they have a lesion in the opposite hemisphere of the brain, and usually that's going to be a stroke. All right, another asymmetrical gait is a steppage gait, and so there are several things that can cause this. Basically, a steppage gait is where the foot drops down, so the patient can't normally dorsiflex or bend up the foot, and so when they walk, it's kind of hard to illustrate this, but the foot here flops down. And so if your foot is dropping down like this, in order to avoid tripping, you need to use the more proximal muscles to lift your leg up higher. And you really need to see a video of that, which I will do in class to kind of appreciate that. But they kind of lift their leg up high, and then you notice the foot is kind of flopping down here. So one of the more common causes here would be a peroneal neuropathy or a fibular neuropathy where we have a foot drop. All right, an antalgic gait is not really a neurologic thing. This is more of an orthopedic issue. If you've ever sprained your ankle and you walk gingerly on the leg, or you've hurt your leg in some way, you're going to kind of have a limping gait, and we call that an antalgic gait. So the neurologic examination is going to be normal in that case because this is not a nerve problem. Now, if we have a symmetrical gait disorder, we want to divide that into either wide-based or narrow-based. So just watch someone walk that's unsteady. Are the feet far apart or are they close together? If they're far apart, then it's most likely one of these two conditions. All right, so a sensory ataxic gait, even though the word ataxia is used, this is not a problem in the cerebellum. The problem is the patient has a severe proprioceptive deficit. They don't know where their legs are in space. Okay, so if you don't have any proprioception, okay, then when these patients walk, the legs are far apart and they're trying to get some information to the brain about where their feet are in space, and so this tends to be a stomping gait. Okay, and so I often just having the patient walk in from the waiting room, very loud gait, stomping down on the floor. Right away, I'm primed to think, okay, do we have a proprioceptive issue going on here? And later on, we'll go over different things that can cause a proprioceptive problem. All right, a cerebellar lesion can also cause a wide-based gait. And remember, the vermis, the midline of the cerebellum, is most important for midline truncal musculature. All right, and so this is also wide-based, but it doesn't tend to be stomping. They're just they're trying to stabilize themselves because of the ataxia, so they have a wide stance to avoid falling. And again, the rest of your exam here is going to be helpful. If we think we're dealing with a sensory ataxic gait, we'll go on and do the sensory exam. Does the patient know whether their toe is being moved up or down? And in a sensory ataxic gait, these patients will have epicritic deficiencies. They'll have a loss of proprioception and also a loss of vibration on exam. If we're just purely dealing with a cerebellar ataxic gait, your sensory exam will be normal proprioception. Right now, a narrow-based gait can be one of two things. One would be a spastic or an upper motor neuron gait. All right, and in this situation, we call it a scissored gait because as the patient walks, one foot literally crosses right over the other. And if you look at the video links in Canvas, I have a video of a patient with multiple sclerosis, which can damage upper motor neurons on both sides of the brain. And when he walks, you can see his feet cross over each other. So a scissored gait means a bilateral upper motor neuron lesion, and there are lots of things that could affect bilateral upper motor neurons. Probably the most common thing is cerebral palsy, actually. Okay, so look for that narrow base gait with scissoring. All right, and then finally another narrow base gait, otherwise known as a festinating or shuffled gait, is Parkinson's disease. And patients with Parkinson's, they tend to bend over, flex like this. The weight of the body kind of gets in front of the feet, which can make it very easy for them to topple over. We'll look for a little tremor, hand tremor when they walk, and the feet shuffle, kind of close together. They don't take big step strides, and they just kind of shuffle along. Their walking is very slow. Okay, so that's a big picture of different gait disorders, and we'll be going over all of these different examples here when we get into more of our clinical neurology part of the course. So I just wanted to finish up summarizing. One of the most important things really in the whole course is that you know the difference between upper and lower motor neuron lesions. All right, so remember, if we're talking about the cortical spinal tract, that travels through the brain, brainstem, and spinal cord. And of course, the spinal cord is not really out here. There isn't a long nerve out like this. This is just a pictorial representation, right? But the cortical spinal tract travels down and supplies anterior horn cells to move muscles here in the arm for the cervical cord and for the leg here in the lumbosacral cord. So if we have a lesion, certainly up in here, we're going to have upper motor neuron findings in the arm and leg. If our lesion is maybe down here in the thoracic cord, we're going to have upper motor neuron findings just in the legs. All right, so both patients with upper and lower motor neuron lesions have weakness, but in an upper motor neuron lesion, remember, it's spastic, the velocity-dependent spasticity. If we have a lower motor neuron lesion, like a problem with the nerve root or the anterior horn cell, this is all lower motor neuron. Okay, the patient is weak, but when you check muscle tone, there's really no muscle tone. It's a floppy, flaccid muscle weakness. Reflexes are key. Are the reflexes really brisk, abnormally brisk in the weak patient? Then it has to be upper motor neuron. Reflexes go away in a lower motor neuron process. And this is just so quick, easy to check. Frequently I get a call from the emergency room. We have a patient who has 2 days of diffuse weakness in the arms and legs. And the first thing that really I want to know is, what are the reflexes? If the reflexes are brisk, it's upper motor neuron. Maybe the patient has cord compression or something like that. If the reflexes are absent, then this must be a lower motor neuron process. Remember the Babinski sign, the toe goes up in upper motor neuron lesions. It does nothing, or it goes down in a lower motor neuron process. Tone is increased or spastic in upper motor neuron. It's decreased or flaccid in lower motor neuron. Atrophy, remember, is prominent. Should put 3+ signs here, probably, for a lower motor neuron lesion. In something that's upper motor neuron, you get a little bit of disuse atrophy, but it's relatively mild. Okay, and remember, fasciculations in the context of weakness tells us it's a lower motor neuron process. We don't see fasciculations in upper motor neuron conditions. And when we get to a test, a very important test that we do as neurologists called an EMG, or electromyography, where we actually put a little needle into the muscle, and that goes into a computer. We get an electrical representation of what's going on in the muscle. In that test, we can see fibrillations, which are a hallmark finding of lower motor neurons. So you can't see fibrillations on the neurologic examination. That is only something that we see with the special EMG test.